Hello and welcome to part 3 of the series of lectures on calcium. Calcium, the very important element in our body, but yet with a very narrow margin of safety, 9 to 11 milligrams per cent, and with adverse outcome if the values go on either side. It's also an important component of the bone, and so in the first two parts, we saw how its levels are being maintained, the calcium homeostasis, the hormones important for it, vitamin D, parathormone, and contribution of estrogen as well. In the second part, we saw what happens in the bones, the bone remodeling units, and what helps the bones to remain healthy and what can damage it. And now we will go on to see the details of the three beneficial hormones, that is vitamin D, parathormone, and estrogen. We'll see the physiological roles, clinical indications, limitations, adverse effects, and therefore precautions while using these hormones as drugs. But before going on to these hormones, let us first take a brief recap of what we saw last time. Importantly, what is osteoporosis? Literally, it is porous bones, which happens because at the bone remodeling units, dissolution is more than the deposition. So deposition lags behind. What are the implications? What happens if there is osteoporosis? It makes the individual more prone to development of fractures even without any trauma. And the commonest fractures seen are the vertebral fractures and hip fractures. Both can be very deleterious to health because vertebral fractures, vertebral compression fractures can cause nerve compression, which can be very severely painful, and hip fractures compromising the mobility of an elderly individual, because osteoporosis we saw is common in the elderly individuals, that can be very deleterious to the health. Other bones can also be affected. The physiological components which prevent osteoporosis are sufficient synthesis of vitamin D in the skin, ability to activate vitamin D to calcitriol, and the two hormones required for this activation, parathormone and estrogen, availability of these hormones. These would protect the bones. The lifestyle components which also are protective for the bones is calcium-rich diet, weight training exercises. Any exercise against gravity is weight training. Exposure to sunlight for the formation of vitamin D3 itself. And all this we saw will ensure building up of bone density only till the age of 30. But the same lifestyle needs to be continued even further to maintain the bone density developed till the age of 30. The lifestyle components therefore to be avoided because they're detrimental to bone density are alcohol, cigarette smoking, sedentary life, and inadequate dietary calcium. With this, let's go on to see the actual details of vitamin D, parathormone, and estrogen. Let's start with vitamin D. We've already seen that vitamin D is synthesized in the body, so now we refer to it as a hormone. So it's synthesized in the body from the raw material cholesterol, which in the skin, under the influence of UV light from the sun rays, is converted into cholecalciferol, or the conventional vitamin D3. It subsequently is converted ultimately to calcitriol by addition of two more hydroxyl group, one in the liver and one in the kidneys. And the rate of hydroxylation in the kidneys is a rate limiting step. And this is facilitated by parathormone, estrogen, and prolactin, so that active calcitriol would be formed. And this active calcitriol works through its own receptors, the vitamin D receptors, VDR. They're cytoplasmic receptors. They're not on the cell surface. They're within the cells, and they're accessible to calcitriol because we saw vitamin D is a fat-soluble vitamin. So it can cross the cell membranes to go into the cells and interact with its intracellular receptors, cytoplasmic receptors, vitamin D receptors. Interaction with the receptors in the kidneys and in the intestines will promote absorption of calcium as well as phosphate. And the method of absorption is bimodal, that is facilitated diffusion with the help of calcium binding proteins, calcibindin, and vitamin D favors synthesis of this calcibindin, the calcium transporting protein. However, any synthesis by the cell takes time, but endocytotic capture can be a faster mode of absorption of calcium. So there is increased absorption of calcium as well as phosphate from the intestine, as well as reabsorption of calcium as well as phosphates from the renal tubules. Why am I laying stress on calcium as well as phosphates? Because both these are required for bone mineralization. Calcium alone is not sufficient, and we will see that parathormone promotes only calcium reabsorption from kidneys and causes hypophosphatemia, which is bad for the bones. On the bones, vitamin D receptors are there inside the osteoblasts, and activating these receptors, vitamin D will make the osteoblasts release two substances, rank L, to activate the osteoclast precursors into active osteoclasts, which will dig the pit, and then release of osteoprotogerin, the substance which will capture and inactivate the ligands when sufficient pit has been dug, so that osteoclastic activity will be stopped. And then the osteoblasts are themselves made to deposit the osteoid, the bone matrix protein, in which mineralization will take place. And this mineralization is also facilitated by vitamin D because it makes available both the minerals which are required, that is calcium and phosphate. So vitamin D will promote bone deposition, though it is also causing bone resorption. And if resorption and deposition go parallel, we saw it is helpful for bone health because new bone is being formed. What happens if there is vitamin D deficiency? If the vitamin D levels 25 hydroxy D3, that means one more hydroxyl group has been added in the liver. That's this molecule we get, 25 hydroxy D3. If the levels of this molecule are less than 15 nanograms per ml, it will affect the calcium levels. And if calcium is low, we saw it will directly trigger the release of parathormone. And we've already seen in the last session that if the levels of calcium go below 8 milligrams percent, normal range is 9 to 11 milligrams percent, and just 1 milligram less than normal can trigger the release of parathormone, and it can be increased to the level or to the extent of 5 times the basal levels of parathormone. And this parathormone is supposed to restore the calcium levels, and it has 3 ways to work. One is activate vitamin D so that gastrointestinal absorption of calcium as well as phosphate will be facilitated, or cause renal reabsorption of calcium, or third choice is bone resorption, promote bone resorption. If high levels of parathyroid are released in presence of vitamin D deficiency, there is no vitamin D to activate. And so gastrointestinal source of calcium and phosphate is not available. If calcium levels are themselves low, they won't be much filtered and thereby provide calcium by reabsorption. So major source which is available for parathormone to restore calcium is bone resorption. Another important thing is, as I just mentioned, on the renal tubules, the effect of parathormone is reabsorption of calcium but loss of phosphate. And this hypophosphatemia also would adversely affect bone density. So high parathormone released in absence of vitamin D is detrimental to bone health, and therefore vitamin D levels should be above 20 nanograms per ml to avoid all these consequences. And so this is referred to as vitamin D sufficiency is when it is more than 20 nanograms per ml, and deficiency triggering all these deleterious events is when the levels go below 15 nanograms per ml. So if there is deficiency, how do we make it up? How is vitamin D available for administration? Vitamin D is available in three forms. The conventional D3, that's the first molecule formed in the skin itself, cholecalciferol, has been used for so many years as vitamin D. It is available as an oily solution, so intramuscular injection, or it is available as oral granules, tablets, or sealed capsules called pearls. The preventive prophylactic dose is 400 units per day of cholecalciferol, that's D3. Or therapeutic dose is 3000 units per day or 60,000 units every 3 weeks for 3 weeks and then every 3 months. So 3000 units per day or 60,000 units per week for every 3 weeks and then every month for every 3 months subsequently. There is one concern about vitamin D, that it is a fat soluble vitamin and can cause accumulation and cause hypervitaminosis D, but that is seen only if we take 40,000 units per day. So vitamin D has a wide margin of safety, and accumulation to cause clinical hypervitaminosis D, clinically significant, 40,000 units per day is the dose which can result in this adverse accumulation. The active forms available are where only that one hydroxylation has been done, the critical step of the kidneys has been done already, or both the hydroxylations have been done. That is, calcitriol is also available. And you can see the doses of these active forms are in micrograms, whereas 400 units could be about in milligrams, the dose. But even if the dose is smaller for the active forms, the cost is much higher. So vitamin D conventional, along with calcium, the tablets cost around 50 rupees for 15 tablets. So just 100 rupees per month if it's to be taken on a daily basis. Whereas calcitriol or alpha calcidol, it is 150 to 200 rupees for just 10 capsules. Apart from the cost, we should never provide something which the body is already capable of doing. So the body is capable of hydroxylation. We do not prescribe the active forms of vitamin D. They are to be given only if renal hydroxylation, the 1-alpha hydroxylation step, is inadequate in that individual, not sufficient. And who are the individuals who would not be capable of that 1-alpha hydroxylation, which is the important step happening in the kidneys? So obviously, if the kidneys are not working, so chronic renal failure or chronic kidney disease patients would not be able to activate vitamin D to calcitriol. And so they would require this supplementation with the active form. Vitamin D dependent rickets is a genetic abnormality where again this 1-alpha hydroxylation is not happening. Hypoparathyroidism, because parathormone is important for ensuring this activation. And of course, postmenopausal women, because estrogen also helps this step, and in postmenopausal women, estrogen would be deficient. Even with age, this process slows down. So even men above 65 years may not be capable of this final step of activation of vitamin D into calcitriol. So all these individuals should be given the active form of vitamin D. Otherwise, all the other people who may need vitamin D supplementation should be given the conventional vitamin D or cholecalciferol. At this point, I would like to also remind you about another important function of kidneys, not related to excretion or water electrolyte balance at all. That is synthesis of erythropoietin. And so when we talk about chronic renal failure or chronic kidney disease patients, these are two important clinical situations which were likely to encounter anemia and osteoporosis. Because of deficiency of erythropoietin, they can suffer from anemia, and because of deficiency of this activation step of vitamin D, they can suffer from osteoporosis. So Whenever we give vitamin D, of course, it has to be given along with calcium. Again, to understand why, if we give vitamin D without calcium, it will be the same scenario as availability of parathormone without vitamin D. Because if there is deficiency of vitamin D and there is low calcium, and therefore we give vitamin D alone, vitamin D can restore the calcium by three mechanisms: promoting gastrointestinal absorption, promoting renal reabsorption, and dissolving the bones. And if there is no calcium in the intestines to be absorbed, we have not given calcium along with vitamin D. And if calcium is low, not much will be filtered to be reabsorbed. So renal reabsorption also doesn't become a very important source here. And so again, the emphasis would be on bone resorption. So giving vitamin D in a calcium depleted patient, giving vitamin D without calcium would further worsen bone density. And so always given with oral calcium. How do we give vitamin D? Do we give D3 or alpha calcidol or calcitriol, the active forms? Depends on, as we already saw, the ability of the individual of renal 1-alpha hydroxylation, that rate limiting step. If the person is capable of doing it, we do not give the active form, we give vitamin D3. And if this step is deficient in the individual, for whatever reasons we saw, then he or she needs to be given the active form of vitamin D. Prophylactic dose we saw is 400 units per day of D3 or 3000 units per day for treatment. Hypervitaminosis, this also we discussed already, that yes, there is a risk of hypervitaminosis because it is accumulated, but the risk is seen only if 40,000 units per day are consumed chronically. So vitamin D does have a wide margin of safety. How do we monitor? What do we monitor to make sure that the vitamin D and calcium treatment we are giving is adequate or less or more? So we monitor the serum calcium or we monitor the urinary calcium. So 24-hour urinary calcium excretion, if it is between 100 to 250 milligrams over 24 hours, then the treatment is adequate and the response is adequate. If it is seen to go beyond 250 milligrams per day, the renal excretion, it is associated with ectopic calcification, including that in the kidneys, and so recurrent renal stones may be encountered. So the dose has to be reduced if it is more than 250 milligrams per day, renal excretion of calcium. This is how we would monitor the treatment of calcium and vitamin D. Coming to parathormone, which is again a polypeptide, 84 amino acid polypeptide, so available as injection. It works through its G protein coupled receptors, which are on the cell surface, and the important cells, renal tubules and osteoblasts. On the renal tubules, it promotes absorption of calcium, reabsorption of calcium from the distal tubule, and within minutes we can see effect on calcium levels because the reabsorption is facilitated quite quickly. On the osteoblasts, interaction of the receptors on the osteoblasts we saw, it promotes release of the rank ligand, which would cause activation of osteoclasts and digging of the bone pits, that is bone remodeling units. So osteoclast precursors would be activated through these rank ligands. So maturation, activation of osteoclasts is facilitated. So number of bone remodeling units are increased and bone resorption is increased. Release of calcium from bone would be reflected in calcium levels within 1 to 2 hours, whereas renal reabsorption of calcium would reflect in the increase in calcium levels, serum calcium, within minutes. It also promotes proliferation and maturation of osteoblast precursors to active osteoblasts, which will also facilitate deposition of osteoid. So these are common effects with vitamin D. It also promotes renal hydroxylation of vitamin D to calcitriol, and that will facilitate gastrointestinal absorption through calcitriol. We saw one difference regarding renal reabsorption, that it reabsorbs calcium but causes loss of phosphate. Continuous high doses of parathormone are seen to mainly execute or bring about bone resorption. But it has been seen that exposure to intermittent low doses, we see more impact on bone deposition. So continuous high dose exposure or high level exposure is found to result in more bone resorption, but intermittent exposure to low doses is found to favor bone deposition. So whenever we do use parathormone, we are supposed to ensure intermittent exposure to low doses of parathormone. So as I said, it is available as an injectable form because it's a polypeptide. It would be digested in the GI tract. And its T-half is very, very short, 2 to 5 minutes. And so you will find that when parathormone is used to treat osteoporosis, the injection is given on a daily basis. And we just talked about intermittent low dose. So because the T-half is so small, given even daily basis, we are giving only intermittent exposure to parathormone. So we do get a positive impact on bone density, even with daily dose of parathormone. Because the T-half is very short, even daily administration is giving only intermittent exposure to parathormone. And this intermittent exposure is found to be associated with improved bone density. The release of parathormone is directly controlled by calcium by feedback mechanism. There are no intermediary hormones like through hypothalamus or pituitary. It's directly serum calcium which would control the release of parathormone. So adequate serum calcium would control the parathormone release. And we saw that if calcium levels go below 8%, it will immediately trigger further release of parathormone, which can go as high as 5 times the basal rate. We just saw that. Teriparatide is a shorter analog. Parathormone has 84 amino acids. Teriparatide has the initial 34 amino acids. Another difference is its T-half is a little longer, 1 hour. And it is also given by subcutaneous injection once a day. As compared to bisphosphonate, so teriparatide is more commonly used than parathormone itself. And as compared to two agents we would be studying subsequently, bisphosphonates, BPN for short, and raloxifene, teriparatide is faster and more effective anti-resorptive agent. And like raloxifene, it also promotes bone deposition with its intermittent exposure. So resorptive, it is more effective, and even deposition is there, which it shares with raloxifene as well. So teriparatide is the analog of parathormone, which is more commonly used. Bone deposition is seen, as I said, because even this has got short T-half, just 1 hour. So even daily administration is intermittent exposure, and so ultimate effect is improved bone deposition. The action of calcium to control parathormone by interacting with the CASR, that is calcium sensitive receptor on the chief cells of parathyroid hormone, parathyroid gland, that has been made use of by developing a calcimimetic agent. That means the cinacalcet, which has been developed by scientists, like calcium, will interact with these calcium sensitive receptors and control the release of parathormone. When do you think we need this action? So in patients of hyperparathyroidism, if you want to control the release of parathyroid hormone, parathormone, we can use the cinacalcet, which like calcium would bind with those calcium sensitive receptors and control the release of parathormone. That is cinacalcet, PTH release inhibitor, to control the release of parathormone in patients of hyperparathyroidism. Coming to estrogen, estrogen plays immensely important role in maintenance of both bone mass It prevents resorption of bone by preventing osteoclastic pit formation, by preventing the maturation of osteoclast precursors into active osteoclasts and controlling their activity as well, and increasing the rate of death of these osteoclasts, so increased apoptosis. This is to stop the bone resorption, and it positively encourages expression, or it causes expression of the genes coding for bone matrix proteins. So it increases the synthesis of bone matrix proteins, the osteonectin, osteocalcin, even collagen and alkaline phosphatase, all the materials which are required as the matrix of the bone in which minerals are to be deposited. The synthesis of this bone matrix material is being stimulated by estrogen. So resorption is controlled, but depositing proteinous matrix, the synthesis is facilitated. Positive calcium balance is facilitated by promoting the renal hydroxylation to form active calcitriol. Plus, it directly promotes renal reabsorption of both calcium and phosphate. So it maintains the availability, or ensures the availability of both calcium and phosphate. So estrogen is responsible for maintaining the balance between the two activities at the bone remodeling units, controlling resorption, ensuring deposition, so that deposition doesn't lag behind, and therefore it lags behind in postmenopausal women. So it is important for maintaining the balance between resorption and deposition. So when this role of estrogen was realized, plus protective role against ischemic heart diseases, hormone replacement therapy was tried in postmenopausal women to prevent these adverse effects of lack of estrogen and to control many other symptoms of menopause. But this long-term trial had to be halted because at the interim analysis, it was seen that yes, bone health was maintained, protective effects against ischemic heart diseases was maintained, but there was a significant increase in breast cancer and endometrial cancer. The trial had to be halted, and scientists started searching for drugs which would selectively give us the estrogen-like actions, the desired actions, that is agonistic effect on the bones, agonistic effect to protect from ischemic heart diseases, but not agonistic effect on the breast or endometrium. In fact, we wanted antagonistic effect. Okay? And such selective estrogen receptor modulator, which is being used for osteoporosis today, is raloxifene. So raloxifene, given orally once a day, it is a partial agonist. That means it behaves as like estrogen in certain sites, and it behaves as an antagonist at certain other sites. So in the bones, it works like estrogen. So it improves bone density. We just saw the mechanisms at the bone, beneficial mechanisms and effects at the bone. In the liver, it reduces LDL levels. And so again, the protective effect against ischemic heart diseases is maintained. So it protects the bones, it prevents ischemic heart diseases, but it is antagonistic to estrogen in the breast and endometrial tissue. So it does not increase the risk of breast cancer and endometrial cancer. In fact, it is found to reduce the risk of breast cancer in predisposed individuals by 65%. Breast cancer has got a strong hereditary component. So these women with strong hereditary component of breast cancer, they found to be protected from breast cancer by raloxifene. And so this is one of the important drugs which also helps prevent breast cancer. So important drug for prevention or treatment of osteoporosis in postmenopausal women. Okay, because it gives the desired effects in bones, but it does not increase risk of carcinoma. In fact, it is found to protect against breast cancer in the females who are susceptible or prone or have a high risk of development of breast cancer. So that completes our part 3, and we have seen which are the forms of vitamin D, which are the active forms, who should be given the active forms, why should it be always given with calcium, which is the analog of parathormone, why is it preferred and used, which is the drug to control parathyroid hormone levels in patients of hyperparathyroidism, and which is the analog of estrogen, which is preferred to be used, and what are the advantages of this analog over estrogen. So think about it, remember it, and we will see a recap of all this when we rejoin or meet again with part 4. In part 4, we are going to study the latest additions to the drugs acting on calcium homeostasis and the bone. Importantly, the anti-resorptive agents, bisphosphonates, denosumab, and calcitonin. The anti-resorptive agents would be considered in the next part. Thank you.